Hello and welcome to Kingsbridge HealthStyle, the health and wellbeing podcast from the Kingsbridge Healthcare Group. My name is Avril Keys, your host, and I will be putting real patient questions to our consultant specialists from across the group. From diagnostics through to treatment, we will give you the lowdown on what to look out for and when and how you should make an appointment. Thank you to everyone who has sent through their questions. If you do have a question or would like to find out more about any of our services, contact details will be listed within the information box below. So let's get started, and I hope you enjoy listening. Our guest today is Dr. Roger Brown. You're very welcome, Roger, to the podcast. You are one of the private GPs at Kingsbridge Private Clinic. Could you tell me a little bit about your day-to-day job, what it looks like?
I actually work in the Kingsbridge Private Clinic in Ballykelly in the North West, and I work there full-time as a GP. I see what normal GPs see in a day. I have anything and everything coming through the door. What surprised me in many ways was just how similar it was to my job that I had done in the NHS for many, many years. So it's not really any different. The type of things I see in the private clinic are exactly the same as what I saw in the NHS.
And you have been a doctor for a number of years. What's your background?
I studied at Queen's, and I spent the first 3 or 4 years of my postgrad training aiming towards general practice in the Ulster Hospital. And then I had to go to Scotland to get my GP training because it was very difficult to get here at that time in Northern Ireland. Subsequently spent 22 years in Scotland as a GP, but came back 9 years ago to Northern Ireland for lots of different reasons, but I think it was certainly a good thing for me and my work-life balance and family life. But I've certainly enjoyed being back in Northern Ireland amongst my kith and kin. Started back in Northern Ireland with Kingsbridge up in Belfast. Then I went back to the NHS for 5 or 6 years, but I'm now working full time in Ballykelly at their new setup there in the Northwest.
Yeah. So the Kingsbridge, they have GPs both here in Belfast but also in the Northwest, which is great. Saves people the drive.
Absolutely. We're trying to cover the province a bit better. There's now 2 people, I think, pretty much full-time all day, every day in Belfast, and I'm there full-time up in Ballykelly. And
I find it interesting you say that you're seeing the same stuff. I suppose I would have thought that it would be a different kind of appointment, but is it waiting lists and maybe an inability to access GP services on the NHS that's bringing people to you more and more?
Yeah, there's several reasons why I see people in the private clinic. The first most common reason is because people just can't get an appointment, and I do understand that. I've been that guy in the NHS until relatively recently, so I know how difficult it's been with the pandemic and so on. But even before that, there were problems with waiting lists to see GPs. So that's the first reason I see people, is because they just can't get an appointment quickly with their doctor, and sometimes it's for something that they're clearly worried about. Another reason people come to see me is because they feel that they need a little more time, and they know that I would have a little more time in the private clinic than I would in an NHS appointment, which is very time constrained. And often people have several problems, and they really feel that they can't bring more than one, and some GPs actually will limit people to one complaint. So they would come to me with several things, and we try and spend the time to tease these things out and try and get to the bottom of it.
Mm-hmm. So how would it differ then to an appointment that you might have with your NHS GP? It's longer, I presume?
It's longer. Everybody who comes to see me has a half-hour appointment. Now that may involve a history-taking process, obviously, clinical examination, maybe some blood tests, maybe x-rays. All of that can be done in-house on the spot at the time, and you can leave often with lots of information and knowledge about what the problem was. We might have to wait for the blood results to come back, for example, or a urine test to come back. but generally speaking, we can try and get somebody sorted out in-house on the spot on the day, and that's the aim. So that's another thing that's good about coming to see me in a private hospital setting rather than going to the GP surgery, because I have access to everything on site, which is really helpful.
More of a one-stop
It's a one-stop shop.
Yeah. And do you have access though to my NHS records? You know, how much of a backstory do I have to come to you with?
If you'd asked me this question when I worked in Kingsbridge before moving back to the NHS, I would have said, no, we don't have access to that, but now we do. And I'm really pleased that that is something that we've managed to get access to. Every patient's record in Northern Ireland is on a thing called an NIECR. And this care record follows a patient from whatever setting that they see a doctor to another setting. So in other words, your GP records, which will include all your drugs history, your past history, your allergies, and any other significant events, all the x-rays, scans, everything's on this.
Fantastic.
That then can be accessed by a hospital consultant if you happen to be admitted to a hospital ward, or an A&E consultant or junior doctor if you attend A&E. But now we can access that in the private sector as well.
That's great. So it cuts out a lot of that, because you talked about taking history, but you wouldn't have to go back so far to explain everything.
It's really important though that we make sure that the patient gives us authority to open their and to access this record, because it is a confidential document. So we do always ask, you know, can I just open this NHS record? And nobody has refused me so far, because it's clearly in their interest to do so.
Of course. And in terms of, you know, I suppose, what kind of situations or cases do you feel it's really beneficial to go and get that private appointment? What kinds of things people might be going through? And I guess they're kind of like red flags as well.
Yeah, there are red flag things, but I would say the things that probably patients would value most about coming to me is where they have been struggling to be heard because they don't have time to tell their story in a 10-minute slot, or it's a complex story and they have tried 5 or 6 times with different GPs, and they really want somebody to just pause for a moment, take stock of the whole story, try and tease it out with them and get to the bottom of it and see what the root cause is. And I have to say, I find that a lot of patients that would come in that situation do end up satisfied because they have had a chance to properly air the problem, and they feel that somebody has actually listened to what they're telling the doctor and hopefully getting the answer. Now, it's sometimes some of these problems are just very, very difficult, but I would say that in a lot of cases, certainly we've been able to get to the bottom of it just by taking a little bit more time and teasing it out together.
Yes, and having access presumably as well to a wide range of specialties within a small team.
Absolutely. I have access to many consultants in all the different specialties. So if I need a specialist opinion, I can bring somebody in. So that also is very, very helpful. Basically, I feel that in the situation I'm in now, I'm ideally placed to get the job done. You know, I have time, I have resources, I have access to various different tests or consultants. I get the job done because we've got all that's necessary to get the job done on site, whether it's up in Belfast here or up in the Northwest in Ballykelly where I'm working at the minute. And
you have obviously all your years of experience as well, so you've sort of seen everything there is to see.
Certainly I've seen a lot in over 30 years, and I've seen a lot of changes. Sadly, not a lot of them are for the best in terms of the way the NHS functions, but I have to say a lot of the progress that has happened and the progressions that have happened within the NHS and in cancer care and other things have been quite significant.
Yes. And what has been your experience, I suppose, moving from, so you went from NHS to private, back to NHS and back to private?
It's been an interesting a phase, I suppose, of my life now to go back into the private sector. I really enjoyed being able to deliver the goods. I enjoyed that aspect of my work in Belfast, and it was purely geography that was the reason I moved back to the NHS to work nearer home. But thankfully, I live near to where I work now in Ballykelly, and that's worked out well. But it has been, I've learned a lot from moving back and forward between the two sectors, the private sector and the NHS. But I am still obviously NHS trained and very loyal to the NHS as an entity, and I certainly would view myself not as somebody to threaten the NHS, but somebody to complement the NHS, someone who could maybe take some of the pressure off the NHS just by being able to see some people that maybe the NHS are struggling to see.
Yes.
So every person that I see, it's one less that my GP colleagues who are under pressure, or that's one less that they're going to have to see.
And on a practical level, if you prescribed a drug to me, what way does that prescription work? That's a question that's come in.
Well, that's a good question, and it's a question that lots of patients have asked me. But essentially, if you come to see me in the private sector, you get a private prescription, and that means you have to buy the drug at the pharmacy. But that's how it is in the Republic of Ireland, and has been for a long time, and it is the case in most other countries. But if you come to see me, you get a private prescription, you have to pay for the drug.
Understand. Very good. And then would my GP know that I had been to you? You know, do you let my own NHS GP know that I have
That's
visited?
a really good question, and the answer is if it's something significant that you've come about and we have found something wrong, then absolutely I will write to the GP in question and inform them that this patient has been to see me and that we've found this particular problem. If we've made a change to medication, I would always write to the doctor and say, look, I've found this and I've suggested reducing that dose and adding in this medication, so that there is a communication between us. But truthfully, that's not happened all that often. It's not necessary all that often. What I hope will happen in the near future is that we, as a private service, will be able to populate the NIECR and add in drugs and findings, scan results and so on. There is a way with another website that is shared for scans and x-rays and so on that consultants and myself can look at results, and GPs can look at results as well. But that's a different setup altogether. That's called the Northern Ireland PACS system. But for normal stuff, I would love to be able to populate the NIECR, and that's something that hopefully will come in time.
Yeah, and it makes sense, I guess, so that everybody knows the whole story and it can complement each other, like you say, can complement the regular GP. I suppose there's, I mentioned red flags, and I guess just from a GP perspective, what are the things that if people experience at home, they really should be making an appointment very quickly?
My word. Well, that's a whole talk in itself, probably. But if something has changed and you've got a bad feeling about it, I think that's something that you should bring to your doctor's attention. And if you can't get to see your NHS doctor, by all means, you can see one of us in the private sector. If you've unexplained weight loss, or you've unexplained bleeding, or you've lost your appetite or your energy, any of these things, or you've found a lump or a skin thing that has changed, and any of these things, there's just so many, it's hard to pick out one or two or three, but if you think that there's something different that's not you, then I think most people get a gut feeling about things.
I was just going to say, because the other doctors have said that, you just get a gut feeling that something's not right, then trust that instinct and deal with it. And we're going to test your knowledge now with a few questions from people. So we've had vertigo, the best treatment for vertigo, dizziness and nausea. And I know it can be a tricky one to treat.
Yeah, well, I wouldn't propose that I'm an expert in vertigo, but certainly it's something that I've seen a lot of as a GP. Vertigo has different causes. This dizzy head. There's two things actually. There's a lightheadedness on one hand, and there's a spinning, dizzy head on the other hand. Now, lightheadedness is probably something that's to do with low blood pressure or medication that you're on that's not agreeing with you or something like that. Dizziness is really what I would suggest is what vertigo properly is. And that again that's a whole talk in itself, but it can be caused by viral things, various different viruses. Viruses similar to the common cold virus actually can attack the inner ear and make you dizzy. There's a couple of other reasons. The most common is this thing called benign positional postural vertigo, or BPPV, and that's a thing where there is a difficulty with the movement of the fluid within the little canals in your inner ear. It can be caused by various things. Sometimes it's a little bit of grit or sediment that forms in the canals. Sometimes it can be because the little nerve endings that are like little hairs that move like seaweed on the bottom of the sea as the waves go in and out. These hairs and these nerve endings detect movement, and sometimes this can be exaggerated. So a little bit of movement makes you think like you're going on a roller coaster around a corner or in a Big Dipper.
Yes.
So the littlest movement can be very, very exaggerated. So there are various different causes for it, and there are various different treatments, but I think if you have got a situation where you're dizzy, particularly if lying down on one side makes you dizzy and you maybe feel like the bed that you're lying on is moving as well, or you're falling in space, that's significant, and I think that's something that you maybe should bring to somebody's attention. Treatments there are medical treatments that are drug treatments, various different medications. I could list probably 7 or 8 that are commonly used, and if one doesn't work, sometimes another one does.
Yeah.
But there's also there's a manoeuvre that is used to test if this is a truly labyrinthine problem, and this Hall-Pike's manoeuvre to show if you have this inner ear problem where your eyes start to go like this whenever we move you a certain way, and then following that an Epley manoeuvre, which someone who is trained to do this can do to try and correct the problem, move the sediment, if you like, try and clear the canals and make the dizziness go away, essentially. It's not a pleasant thing to have done to you, but it is something that it does work very, very well. So if you can bear with the doctor, or physios do this as well, you can bear with the physio with the doctor, it certainly can pay off. So there is another thing I want to say about dizziness though that is important, and that is that it can be a sign of something more sinister. It's not usually, but it is on the list, down towards the bottom of the list of important things to consider. So I do think if you're having persisting dizziness that it's not going away after a day or two, or after you've tried some of the medication, or maybe this manoeuvre, you certainly should have a neurological examination carried out by a doctor, hopefully your own GP, to see that there's not something more sinister going on.
And I suppose that brings me back to the benefit of that slightly longer appointment, where you can actually explore all of these options, particularly if you've already tried a drug approach and it's maybe not worked for you. So I had a woman contact me about her teenage son whose skin is very bad, has gotten worse in lockdown, has had a number of the kind of topical treatments, and doesn't feel, and I thought this was kind of sad in a way, in that she didn't feel she could be annoying her NHS GP about this because it was a minor issue. And I suppose it struck me then that a private appointment probably would be quite useful in that case, because you could talk through.
Yeah, although I have to say, I think an NHS GP would probably understand that a boy or a girl going through the teenage acne years, it can be quite daunting to go through the teenage years anyway, let alone people maybe making fun of you because you've got a spotty face. So I would hope that doctors would tend to be sympathetic towards that. Nobody's died of acne yet, however, so we've got to keep it in perspective.
Yes.
But certainly there are lots and lots of acne treatments out there. Topical creams are very, very good. There are many out there. Some have antibiotics in them, some are cleansers, some are a mixture of both. There is then the next stage would be to move on to oral antibiotic treatments on a low dose over a prolonged period of time, and that again has been tried for many years and is very successful for many people. If you don't mind taking antibiotics all the time. And then the next treatment is really the Roaccutane treatment, which is something that's a consultant only or consultant led treatment. You can't start Roaccutane until you've actually seen a dermatologist. But Roaccutane was initially just a tablet, but has now been brought out as a gel. And the topical gel, isotretinoin gel, does seem to work very well too. Now that is prescribable by a GP without seeing a specialist, but so that is another option that we have open to us. But certainly Roaccutane makes a massive difference to the really troublesome acne that some poor teenage folks go through, or even adults.
But with obviously, and that's why it's prescribed by a consultant, because it has some side effects.
It has side effects. We have to keep an eye on liver function. There's a complicated reason for that, but Roaccutane can affect your liver function. It doesn't usually, but we need to monitor that. It definitely has a very serious effect on an unborn embryo developing in utero. So we would always suggest that a girl in her teenage years goes on to the pill as a way of preventing pregnancy, or some other permanent or not permanent, but sort of more prolonged, like perhaps the depot injection to prevent her getting pregnant while taking Roaccutane. And that actually brings another point in, because the pill and several pills have been used very effectively for girls, not boys obviously, but for girls in treating acne. So that's another option that I had forgotten to mention on the way through.
And again, it feels to me like a longer appointment would be so much more beneficial, because you want to talk through the different options and give people different approaches to it. In terms of, and we had in our last series of the podcast, we had a menopause specific podcast, and a number of women who've contacted me have said that they struggle sometimes to get that time with their GP to really talk through how they're feeling, particularly in perimenopause. So can you share with me the expertise within Kingsbridge in that sort of space?
Yeah, well, we have a GP with a specialist. It was Dr. Lisa Nelligan, and she has been doing this very thing. She has been running menopause clinics at Kingsbridge, along with a couple of the gynecologists, but one in particular, Dr. Frances Stewart, has been involved very much in guiding this service. And these two ladies are experienced and knowledgeable and caring and understanding, so I do think, and obviously have the time as well. So I think that's something that I can say confidently, that people will feel listened to, and that they will hopefully go away with the sense of having got the best service possible for these perimenopausal or menopausal symptoms.
And they're based in Belfast.
They're based in
Belfast clinic.
Well, Dr. Stewart actually is also up in Ballykelly one day a week, so she does operate from there as well.
That's good to know. And you would have an interest yourself in men's health, and we have a further podcast that will cover prostate in particular, but is it fair to say men are less keen on going to the doctor?
Yeah, they are. It's getting better, but men generally only come when they absolutely have to. Men are not good at seeking the doctor's advice about things. They just kind of hope that it'll go away. And often they're prompted by their wives or mothers or girlfriends to come along because something is wrong. So men are not good at it, but they're getting better. They're getting better.
And so what kinds of things in that men's health space do you
Well, ever since my first day as a new doctor in a urology ward where I was working for the first 6 months of my clinical life as a urology junior doctor, I've had an interest in men's health, I guess. So we have developed a one-stop shop for prostate assessment at Kingsbridge in Belfast, which I hope to reproduce up in Ballykelly shortly, where a guy would come in with a problem, would have the history examination, the flow test, the bladder scan, the blood tests, everything done all on site in the one day in an hour and a half or something like that. Fantastic. And you go away knowing if you have or you haven't got a problem, if you need to see a specialist or you don't need to see a specialist. Can we treat this with medication or do you not need any treatment? So that's one thing, but I'm also keen to see men who have got other issues. Testicular problems are a thing that we really must get the message across. If there's a change, particularly a painless enlargement of one of the testicles, then that is something that really needs addressed quickly, because that can be something sinister. It may not be, but it can be. Please bring any lumps to somebody's attention, a lump in the testicle or the apparatus attaching to the testicle. That's very important as well. Erectile problems, that's something that I have lots of experience of dealing with and helping men with. And that's clearly a thing that we're encouraging men to speak about more, because it was something that was just frowned upon taboo in the past, and it was a taboo subject. So, but we're happy to discuss that at length and in depth if necessary.
And I'd imagine it's easier for a man to go to a male doctor.
I hope so, and maybe a male that has a few grey hairs as well.
It's been around the block a few times. Is this you were talking about? And what about, obviously, heart health?
Heart health, that's a biggie. In Northern Ireland, we lead the world in something, unfortunately.
Not a good thing.
It's heart disease. And we're getting a wee bit better at it, and certainly coronary interventions have dramatically changed things from my early years as a junior doctor to now. The idea of stenting and bypassing so many people now is something that just was unheard of when I first qualified. So bypasses were happening, but not stenting, and not the first angiogram I saw was in Israel as a third-year medical student, a coronary angiogram. So we've come a long way in 30 years. So heart health is a big thing.
Would that present in pain, I guess? Would it be people feeling?
Yeah, most people who have heart trouble, it's a pressure or a pain or some sort of tightness around the chest that they're getting, and that's what is presenting as a heart problem. Usually on exertion. So in other words, if you go upstairs or you run for a bus and you feel this tightness or this pressure or a heaviness, that could be an indication that you maybe have angina. If it's something that's a sudden onset, that literally you're stopped in your tracks and you feel like there's an elephant sitting in your chest, that's a 999, because that's probably a heart attack.
But the lead up to it, maybe where you're feeling that pressure is where you need to...
The niggly, achy pain in the chest, down the left arm, up into the jaw sometimes, that's a bit of a warning sign. And if you're getting those niggly problems, please, men, come and get seen.
Yeah. So, Roger, is there anything that you offer in the surgery in Ballykelly that maybe wouldn't be available in a regular GP surgery?
Well, I'd alluded to the one-stop prostate shop, which I hope to start soon. But another thing that I do, which is not commonly available, lots of GPs can do this, but not many really are able and have the time to do this in practice, and that's pain injections, joint injections for sore knees, sore whatever joint it is. We actually end up carrying a lot of patients for a long time as GPs, as they wait not weeks or months but years now for joint replacement surgery. So things like knees that are very painful and very stiff, I can do a knee injection to give somebody pain relief for maybe 6 months. And that's something I think is very, very helpful, just to keep people going for a little bit longer, to help them get through. and maybe to avoid the necessity of some heavy-duty pain-killing drugs, because by the time most people come to see me for this kind of a thing, they're already finding that their strong painkillers aren't really helping anyway. So,
and is that just a regular appointment then, like a regular half-hour appointment?
Regular
that you would
half-hour
make?
appointment,
Okay.
and I will talk the patient through all that is required. I actually am involved with Kingsbridge Training Academy here, teaching other GPs to do joint injections, along with a colleague, Ryan Hamilton, who's another GP with an interest. And so I'm actually trying to promote this as well, because I do think it's a very, very useful tool for GPs to have in their bag of tricks, if you like. So we can offer joint injections or trigger point injections for various different pains that actually do respond very well. Sometimes to just a local anesthetic, but sometimes it's also with a steroid.
Steroid in it. And does that mean you wouldn't have to take your pain medication then, potentially?
It certainly would reduce the need for the strong pain medication, and maybe allow people to take something like paracetamol instead of an opioid medication like the strong cocodamol or tramadol or some of these things.
And obviously get them moving again, which is
the whole thing, yeah. And one of the things that we've been working with in the North West clinic in Ballykelly is that if somebody's coming in, for example, with a frozen shoulder to see the physio, they need to get the physio to work with this frozen shoulder, but because it's too painful to move, they come to see me, I give them a local anaesthetic injection, 5 minutes later they go to see the physio, they have the treatment, and so it's something that we're working in partnership with, again, because we're on site all together.
Yeah. And then obviously mental health, which is something
health,
we've not, maybe men haven't been so good at opening up about.
And it's a sad thing to say that suicide rates are ridiculously high at the minute, and it's mostly men that are doing this. So we really want to intervene and prevent these unnecessary and very sad deaths.
And what can a GP do for that? I'm imagining that men might think, well, there's no point in going to the GP to just talk.
Well, this is actually a very interesting point, because people who are suicidal are often depressed in the lead up to this, and when people are depressed, they kind of think, well, what's the point? They're not going to listen to me anyway or whatever, because they're in a very negative frame of mind. What I would say is that as a profession, the medical profession and the nursing profession has wakened up to just how important it is to deal with depression in the early stages, to deal with it at any stage actually, and to try and help people to navigate depression, because it's a horrible thing to feel, and it can lead to other illness and sometimes, as say, suicide or death. So we want to help.
Yes,
absolutely.
And I'm thinking again, I keep going back to these longer appointments, but I'm guessing that you could have somebody present with one thing that you then subsequently, through that longer discussion and chat, may pick up on another issue that's brewing.
It's a thing we're taught about in GP training, there's a guy talked about the inner consultation, and it's really important that GPs are aware of body language and subtle cues and clues that patients might give us. Now, honestly, it is really hard to be aware of all of that whenever you've only got 10 minutes and you're already running 20 minutes behind perhaps, and to pick up on these subtle clues is really difficult. But what I would say is, I hope my colleagues would be open-minded enough and open enough to the patient to try and pick up on some little things along the way, because certainly people come with depression to a GP and they're actually presenting with a sore big toe or something because they don't want to present with depression. And what is really difficult, and please believe me out there, is if you've got 2 or 3 things that you've dealt with, and then you've already given the patient 10 minutes, and they said, I really need to tell you, doctor, that I really have been feeling very depressed for the last 6 months. That is not what a doctor wants to hear at the end of an already perhaps lengthy consultation. So bring it at the beginning. Bring it at the beginning of a consultation, or be prepared to have another chat about it another time. You maybe reschedule and come back another time.
Yeah, no, it's I can imagine it's difficult, and the benefit of having that bit of extra time with you.
Honestly, everything that we've talked about today is so much easier for me, and therefore I think also so much easier for the patients if they have the time.
Yeah.
So that's where I think I get most job satisfaction out of this, is because I get the time to try and tease these things out with people, and hopefully the patients then benefit from that.
Yeah. And you realise it's not really the big toe that's the problem.
Absolutely.
Yeah. And I guess I like to finish asking for kind of hints or tips on how to be more healthy. So have you any kind of personal...
I like to keep things simple. I'm a straightforward person. I like to keep things simple. And if you're a smoker, the biggest health benefit that you could do is stop smoking. Okay. So that's in a nutshell.
What about vaping?
Vaping is not great.
Okay.
But it's better than smoking because you're not getting so many contaminants into your lung.
Okay.
And I would be happier with somebody vaping as smoking.
Okay. But
that's a simple, easy to take home message. If you're a smoker, there's nothing you can do more beneficial than stopping smoking. The other simple things are, as a population, we are over, and this is not for everybody, because I know there are people out there that maybe are healthy weight and maybe some people even who have eating disorders, and I don't want them to hear the wrong message here, but as a population we are overweight. The last survey, which was done last year, looking at the likes of GP records and what weight people are on their GP records, is that 64% of the UK population is overweight. That's defined as a BMI of over 25. And the really disturbing thing is that 28% are over a BMI of 30. So that's obese. So we're in a really bad situation in terms of weight in the UK. A third of our children between 5 and 19 are overweight already. So this is making problems for the future. Why is this? Well, it's because we drink too many sugary drinks and we don't eat enough fruit and vegetables. And that's proven. We have the stats to back this up. We are the worst in Europe. We're not the worst in the world, but we're the worst in Europe in terms of obesity. So try and cut out the sugary drinks, try and eat more fruit and vegetables, try and eat less generally, because a woman needs 2,000 calories a day on average, a man needs 2,500, and we all eat more than that, or most of us do. So that's another simple thing. The final take-home message again, and I guess would be, do a bit more exercise. We know that 20 minutes of walking, brisk walking 3 times a week is enough to make a difference. So why not do a little bit more than that? You know, people talk about getting their 10,000 steps a day. Keep active, by all means. Count your steps on your phone or whatever, but get a little bit more active, eat a little bit less, and if you're a smoker, stop smoking.
Well, thank you very much, Dr. Roger. That's been fantastic. Appreciate you speaking to us today.
That was a pleasure.